So what is our MR protocol? So usually we take T2 weighted images, ideally in 3 planes at the FSC or TSC. You take actual T1 weighted images with or without suppression. We take diffusion weighted images and ADC maps. If only 2 B values can be acquired because time is constraint, then the lowest B value should be at least 50 to 100 and highest should be at least 800 to 1000. Then we acquire a separate set of high B value images. These are not to be calculated from these diffusion. You have to have a separate set of high B value images of about 1400 to 2000 sec per millimeter square. This, when you compare this to ADC maps alone, this increases the conspicuity of clinically significant cancers on high B value images. Especially, it's important in those cancers which are adjacent or invading the anterior fibromuscular stroma, if they are in a subcapsular location or at the apex or the base of the gland. So it's very important to take this sequence of high B value images. Then we have the DC, which can be carried out for several minutes. The temporal resolution should be at least less than 10 seconds and preferably less than 7 seconds. We must do this with fat suppression. That's the standard dose and the injection rate. And then there are a lot of software available which is able to superimpose all these sequences into one CAE technology. So this is what the normal prostate looks like. That is the base of the prostate, which is just below the urinary bladder. This is the mid gland of the prostate. This is the apex of the prostate. It's divided into 4 histological zones which can be very well delineated on the MRI. That is the anterior fibromuscular stroma, which is there at the base just below the urinary bladder and in the anterior-most portion. It does not contain any glandular tissue at all. Okay. Then we have the transition zone which is surrounding the urethra. You can see here also the transition zone which is surrounding the urethra. Okay. It contains 5% of the glandular tissue. Then we have the central zone which surrounds the ejaculatory duct. So this is the central zone which is seen on the coronary images. It contains about 20% of the glandular tissue. And then we have the outer peripheral zone which contains about 70 to 80% of the glandular tissue. And this is where most of the prostatic cancers occur. ACR and the PI-RADS is divided into various sectors, 39 sectors in PI-RADS version 2, 36 for the prostate, 2 for subanal vesicles, and 1 for the external urethra. This is important. You must, whenever you detect a lesion, you must say in which sector it is because this helps in the biopsy. This helps also in the clinician following up and in planning his surgery. The assessment and reporting system was used basically because to identify and localize abnormalities that correspond to, again, clinically significant cancer. So this is what the definition of clinically significant cancer was. It's defined on pathology or histology as Gleason scores greater than or equal to 7. And this basically divided the gland architecture into one which is looking absolutely distorted to less distorted. So the more distorted or the more abnormal it is, the higher Gleason score you could get. So coming to T2 and T1 weighted sequences, T2 weighted images, they're important for delineating the zonal anatomy, abnormalities within the gland, invasion of subanal vesicles, extraprostatic extension, and any nodal involvement. T1 weighted again is important to exclude the presence of hemorrhage as a baseline before you inject contrast. The normal peripheral zone has homogeneous high signal, it's hyper intense, and the central gland has intermediate signal intensity on the T2 weighted images. This is often replaced, the intermediate zone that is, by well circumscribed hyperplastic nodules in BPH. So this is what a clinically significant cancer looks like on T2 weighted images. You see rounded or ill-defined hypointense lesions which are seen in the peripheral zone. But only T2 weighted images have limited sensitivity because some prostatic tumors can be isointense, and it has limited specificity also because this can be seen in focal prostatitis or hemorrhage or scarring or hypoplasia. So it's never that only one sequence you can say whether this is a clinically significant cancer or no. As far as the transition zone is concerned, you see non-circumscribed homogeneous moderately hypointense. This is called as the erosed charcoal or the smudgy fingerprint. As if you know you've taken a fingerprint and that has got smudged. That is the appearance that you will see. If you see a well-defined lesion, then that is not a clinically significant prostatic cancer. That is likely to be a benign hyperplastic nodule. But if you see a smudged appearance or an ill-defined appearance, that is likely to be a clinically significant cancer. If you see spiculated margins or a lenticular shape, biconvex shape, or this capsule that is seen that is eroded or absent at some point, or if there is invasion of the urethral sphincter or the anterior fibromuscular stroma, any of these or multiple of them, more features that are present, the higher that there is a likelihood of a clinically significant cancer. So let's come to the scoring. There is a separate way to score the peripheral zone. There is a separate way to score the transition zone on each of this. So as you can see out here, if it's uniformly hyperintense, the peripheral zone, let's concentrate on the peripheral zone now. If it's uniformly hyperintense signal, this is normal, and you give a score of PI-RADS 1 to this. If you see linear, as you can see in these images, or wedge-shaped hyperintensity, or there is just a mild hyperintensity with the indexing margin, this is PI-RADS 2. If there is a heterogeneous signal intensity, or there are non-circumscribed, that means it's not well defined, or rounded, or moderate hyperintensity, more than which you see in 2, but not as much as you see in 4 or 5, that is taken as PI-RADS 3. Then if you see circumscribed homogeneous moderate hyperintense mass, which is confined to the prostate. You can see this external capsule very well, and it's greater than it's less than 1.5 centimeter in greatest dimension. This is given as PI-RADS 4. The same lesion, if it is greater than 1.5 centimeters, you can see this large ill-defined lesion which is there in the peripheral zone, is greater than 1.5 centimeters. This is definitely a clinically significant cancer, and it's given as PI-RADS 5. As far as the transition zone goes, now let's leave aside this peripheral zone, let's come to the transition zone. You see this it's not as bright as the peripheral zone. It has an intermediate mixed signal intensity, but it's still homogeneous. So this is given as PI-RADS 1. Now if you see these circumscribed, I told you, if you see circumscribed, these are well defined. You can see the entire margin of this nodule. It's an encapsulated nodule. These are nodules of benign prostatic hyperplasia. This is given as PI-RADS 2. But if you see a heterogeneous signal intensity, which has obscure margins, there are no defined. See, these are BPH nodules, which you can see. But can you see this lesion? It is not very well defined. It's ill-defined. And it has obscured margins. This goes into PI-RADS 3. Again, this lesion, which is lenticular, that is biconvex, or is not well defined, but it is moderately hyper. It is more hypointense than what you saw in 3 than this, but it is less than 1.5 centimeters. It's PI-RADS 4. And then the same large lesion which is not well defined, greater than 1.5 centimeters, okay, this goes into PI-RADS 5. So based on this morphological, that is T1 and T2, how can you stage prostatic cancer? You can define whether it's organ confined versus extraglandular tumor invasion, that is whether it's T1, T2 or T3. Then the sensitivity of this is almost 95% and specificity is almost 97% for detection of this extracapsular extension. As far as extracapsular extension, what are the signs that you must look for? If there is asymmetry or tumor encasement of the neurovascular bundle, if this prostatic contour, you can see this is a well-defined contour, but if there is bulging of the prostatic contour, or if there is an irregular spiculated margin, or if there is an obliteration of the rectoprostatic angle, which I'll show you in the next case, or if this capsule is retracted, or if the tumor capsule interface is more than 1 centimeters, these are all signs of extracapsular extension. This is something why this MRI is carried out. You must look out for this extracapsular extension, because the rest of the modalities are able to tell you whether there is a lesion or not a lesion, whether there is malignancy or not. A PSMA PET will be able to tell you that. But what is the advantage of the MRI is whether there is extracapsular extension or no. This is the big advantage. So this is something you must not miss, must not make a mistake at. You must look out for all these signs when you are evaluating a lesion. Now this is a 72-year-old man which had a biopsy confirmed Gleason 6, 3+3. And you can see there is this rectoprostatic angle which is seen out here. There is effacement of this rectoprostatic angle. Now for seminal vesicle invasion, again one very important sign. So generally the seminal vesicles, they are fluid filled because they are filled with seminal fluid and they are hyperintense on the T2 weighted images. So if you see any focal hypointense signal within and along the seminal vesicles as you are seeing there, or there is a hypointense signal which is seen in the ejaculatory ducts on either side, or if there is an obliteration of this angle that you are seeing between the prostate and the seminal vesicles, or you can see this direct tumor extension from the base of the prostate into and around the seminal. Any of these you see, you must raise the bogey of seminal vesicle invasion. It is very important. It will change the management of this patient. This was morphological imaging. Coming to functional imaging, we have diffusion weighted imaging, dynamic contrast enhanced, and MR spectroscopy, which actually is not there in the PI-RADS version 2. It was there in the PI-RADS version 1, but they've removed it from version 2, but which we still undertake because it does add some value to the diagnosis. So diffusion, you get valuable information at the cellular level It provides an important quantitative biophysical parameter to differentiate benign from malignant prostatic tissue. So it's a quantitative parameter. That is because malignant lesions have lower ADC values than normal prostatic tissue. Okay, so there is a threshold value of 750 to 900. This threshold aids in differentiating between benign and malignant prostatic tissues. The ADC values below this threshold are considered definitely malignant. Above this threshold are considered definitely benign. This DWI and ADC mapping can increase the sensitivity and specificity of MR imaging in conjunction with T280. So they are always to be used in conjunction with it, but they definitely increase the sensitivity and specificity. So how do you score them? Both the peripheral zone and the transition zone are scored similarly. If there is no abnormality which is seen on the ADC or the high B value diffusion weighted images, then it's scored as 1. If there is an indistinct hypointensity on the ADC that we can see, then it is scored as 2. If you can see a moderately hypointense, not very bright, but is definitely brighter than the surrounding tissue on the hypointense on the ADC and mildly hyperintense on the high B value, then it is scored as 3. If it's markedly hyperintense on the diffusion weighted images and markedly hypointense on the ADC maps, but it's less than 1.5 centimeters, then it's 4. And the same is in this as in 4, but if it's greater than 1.5 centimeters, then it is graded as 5. So what are the caveats but when you're using diffusion weighted image? It should always be correlated T2 weighted, T1 weighted and dynamic contrast enhanced images. Some benign findings and some normal anatomy such as calculi, calcifications, areas of fibrosis, if there is the dense anterior fibromuscular stroma and some blood products, if a form of pre-biopsy, they may exhibit they may exhibit hypointensity on both the T2 weighted and ADC maps, but because there is insufficient signal. But these will also show hypointensity on the diffusion weighted images. So this is the caveat. Then some BPH nodules in the transition zone are not clearly encapsulated and they may exhibit hypointensity in the ADC maps and hyperintensity on the high B value DWI. So this is a recognized limitation. We must be aware of this and we use dynamic contrast enhanced imaging to overcome this. If you see an encapsulated circumscribed round nodule in the peripheral zone, it's likely to be an extruded nodule from the transition zone, even if it is hypointense on the ADC maps, and the PI-RADS assessment category for this finding should be 2. Coming to DCE, you acquire rapid T1 weighted gradient echo scans before, during and after IV administration of some gadolinium based contrast agent. So prostatic cancers demonstrate usually early enhancement compared to the normal tissue. But the actual enhancement, one must remember, is very variable and heterogeneous. So that's why not an absolute sequence. So no early enhancement, or if there is diffuse enhancement which is not corresponding to a focal finding, or there's focal enhancement which is corresponding to a lesion which looks like BPH on the T2 weighted and the diffusion weighted images, this all goes into PI-RADS score negative. Okay, but you get this focal enhancement or earlier than contemporaneous or earlier than surrounding tissue enhancement which is corresponding to a suspicious lesion on T2 weighted images or diffusion weighted images, those goes to PI-RADS positive. So what are the caveats for this? Should always be interpreted again, as I said, with T2W and DWI images. None of these sequences have to be taken in a silo. They have to be all considered together. Focal enhancement in clinically significant cancer usually corresponds to focal findings on T2 weighted or diffusion weighted image. Diffusely positive DC, when the gland is diffusely enhancing, it's usually because of prostatitis. When the T2 weighted and diffusion weighted images are of diagnostic quality, this DC plays a minor role in determining PI-RADS category. So this is how it works. So based on DWI, you grade the lesion into PI-RADS 1, 2, 3, 4 or 5. It does not matter what the finding is on T2 weighted or dynamic contrast imaging for 1 and 2. But in 3, if the lesion shows positive enhancement, then that lesion is upstage to 4. Again, in 4 and 5, it does not matter what is the finding on T2 weighted or DCE images. Okay. Whereas in transition zone, you must remember, so in peripheral zone, DWI plays the seminal role. In transition zone, T2 weighted images play the difference. You must remember this, which is important in which. Again, as I said, in a similar way, if it's for PI-RADS 1 and 2, it does not matter what the finding is on DWI and DC. But if it's PI-RADS 3 and you're getting a diffusion weighted images which is less than or equal to 4, it remains 3. But if it is PI-RADS 3 on T2 weighted images and it's 5 on the DWI, then it is upstage to 4. So the tiebreaker for transition zone is DWI, the tiebreaker for peripheral zone is DC. So then based on this, you give the overall PI-RADS category. So first you classify it into T2 weighted images on diffusion, on DC, and based on this, a particular lesion is given a PI-RADS category ranging from 1 to 5. 1, there's very low likelihood of clinically significant cancer, to 5, that there is a very high likelihood of clinically significant cancer.